Today we're joined by Dr. Samuel Lau. He's Vice President for Dental and Clinical Affairs, as well as Chief Dental Officer at BioLays. He's also Professor Emeritus at the University of Florida College of Dentistry and an Associate Faculty Member of the Pankey Institute. He's been a noted speaker and dental expert for many years, and we're pleased to welcome you to our broadcast today. Dr. Lau, thanks for joining us.
Well, thanks, Noah. Really appreciate being here. Looking forward to it.
Well, before we dive into our kind of key topic of today, which is about aerosol reduction during dental procedures, I just wanted to kind of get a sense how you're doing and what the last couple of months have been like for you. Obviously, probably pretty different than a typical spring.
Well, I don't think any of us in any walk of life in any place in the world ever would predict something of this nature and the impact of it. Naturally, I have my ear to the ground for my loved profession of being dentistry. And the impact has been significant, as it has with all. Every now and then, I somewhat go off on a tangent and talk about, playing the violin. Woe is we dentists and hygienists. But then when I look at everyone else, we're all in the same boat. It has actually, if there is a glass half full for dentistry, I know that it is caused us to do some introspection, both personally and professionally. I think that's true for many folks, especially when you're in a lockdown. But I do believe from business practices, as they come back now, I think they have cleaned up some areas that probably should have been cleaned up before, meaning the quantity of their dental team, some of the procedures that they were doing. I mean, it caused us to really take a serious look at where we are. Now, I will admit that when you look at the surveys of what were dentists doing in the first few weeks, in fact, I actually created something called I used the stages of grief and did it for dentists. And it's absolutely perfect, Noah. As an example, the first stage of grief is denial. And that's what my colleagues were doing. First of all, my phone was ringing off the wall, and conversations were much longer with my colleagues as dentists than they ever had been, because before they were seeing patients, now they had nothing else better to do than to just sit there and talk with me. But we were in denial. This really can't be true. Surely this is just some phenomenon. It's a bad dream, and I'm going to binge on Netflix. And then they got to where they said, something? Wait a minute. And then they got into the anger phase with it. But then they started doing what? They started going on Dental Products Report. They started looking at webinars. They started actually doing some continuing education, which actually happened in the recession. And so as you look at the stages of everything, then we went into depression. And then now we're actually in the acceptance mode. Although I must tell you, there are still some dentists out there that are still in the anger mode. But now we're in the acceptance mode. And we're going back, we're acknowledging ADA, CDC. A lot of rumors out there on what we should be doing. A lot of vendors out there selling us things that maybe we don't need, selling us things that probably we do need. So it's just been a very interesting time. I would frame it as introspection.
Mm-hmm. And now you hit on exactly what I was hoping to speak with you about right there, which is there's just been a flood of information coming at dentists from different resources, whether it's the ADA with new guidelines on a daily basis, it seems, or the CDC, or any of the other organizations that have some say in how dental practices operate. They're also hearing from lots of companies out there that are saying, this is a new solution. This is going to help you deal with that infection control thing. And then there's the message the media seems to really like to drive home, which is that the dentist office is such a dangerous place for viral infection. And, we've got all these messages out there. How do we kind of cut through all this? And how do we make sure that, as you said, dentists aren't buying things they don't need, are investing in those things they do need, and we get to a place where, we learn from this situation and we grow and we become a better industry.
Absolutely. We dentists, I want to somewhat pat us on the back for just a moment. We dentists, we went to college, we took courses in physiology, biochemistry, etc. And you're very aware that dental school is 4 solid years, and it's not just about teeth. It's also about virology, microbiology, physiology, biochemistry, the Krebs cycle. So we are scientists, and we are as much aligned as medicine we consider in the healthcare scenario. It's only by politics and et cetera that keeps us from there. But we do work on a very important place called the mouth. And as you know, and I've seen these articles, and thank you, in dental products on the oral systemic link, and they still come out. One recently really clear on Alzheimer's and the link and with the oral cavity. But what I don't think folks remember, because I went through the HIV crisis in January 1990, and there are exceptionally clear parallels between that and what we're going through now. I don't think folks appreciate that the 2003 CDC guidelines are not too far off of the new CDC guidelines. And I see you're acknowledging it because you've looked at that.
Yes.
So it's not like somebody sprung something on us. For the most part, dental offices are pretty clean.
Oh, yeah.
I mean, you look at that. I mean, we are disinfecting everything. Before pre-COVID-19, we were wearing masks, we were wearing eyewears, many of us had shields on when we'll talk about aerosols. We're supposed to be changing our gown on anything that's splattering. So that's not 2020, that's 2003. And some of that actually was born out of the HIV, bloodborne, saliva-borne crisis where we were. I think sometimes I just need to tell patients, wait a minute, we're pretty attuned to infection control for the most part. Now, there's always going to be outliers, but we pretty well take a look at what we're doing, and you're aware of this, that if looking at EPA data, what have you, there's never really been a documented incident of a influenza outbreak or a TB outbreak, SARS, anything of that nature in a dental office. And so I'm not putting down anything that we should be doing. Please understand that. I'm not dumbing it down whatsoever. And I do believe that dentists will do, and their teams will do what is expected. Because we know one thing, the highest priority for a dentist right now, if you're a smart dentist and you're listening to me, is you better make sure those patients know your office is safe. Number one.
I completely agree with that. That's messaging we've really tried to put out there into the world, that dentists have been experts at these procedures for a long time. They have to be. There's a reason why they're at the top of the list, but there's also a reason why that dental practices are always constantly updating their training, always documenting their infection control procedures. It's not new. So if that part of it's not new, and we know that the patients are, going to eventually get the lessons that they need, that this is a safe place, that, yes, viruses are transmitted during it, but usually that transmission would be from the patient's mouth to the clinician and not the other way around. With that in mind, the other topic that seems to have become very big at this time is aerosol generation during a dental procedure. And, practices were advised right away to reduce or eliminate the use of procedures that generate aerosols. And yet that's a huge portion of what many dental practices do every day. So what are some of the things that you've been seeing and hearing about aerosol generation within dental practices, and kind of what's happening in terms of how practices can reduce that to create a slightly safer environment?
Yeah. There again, it's the balance. There's not really a study out there that demonstrates that COVID-19 is in a dental aerosol.
Mhm.
But that also means, because this is the scientist in me being at University of Florida and having done some research, that also means that the studies have not been done. So it depends on how you look at it. But at this point, but that doesn't mean it could happen. However, I do believe that sometimes that we are very vulnerable to information that is coming out. You hit it on the head when you talked about the source of the issue, and that is coming not from the patient's mouth, but from the patient's lungs. Oh, yes, you will see somebody saying, now, did you see that possibly the COVID-19 is in the minor salivary glands? I mean, this is what I hear every 30 minutes, every hour of the day, because I spend 14 hours a day either presenting a webinar, listening to a webinar, talking to dentists. I'm not the expert, but I am also someone who has some common sense. As I was talking to a virologist, you can rinse your mouth out, I don't care, with gasoline and light it on fire. But the problem is if a COVID-19 active patient coughs,
Mhm.
all the aerosol protection in the world is not going to make any difference. So I guess I'm going back to what you said, which I think is very critical. What is the source of the issue? And so I'll frame it for you in this perspective, and this just is coming from Sam, that trying to sort of put the icing on the cake after the cake has been baked, what I'm saying is aerosol control in the office, whether it be UV lights, whether it be filters, whether it be these external things that are sucking up the air. Actually, I was on a webinar where they said, open up your windows. Open up your windows. That is one of your best ways of decreasing the transmission. Well, there are not a lot of dental offices that have windows that you can open. This actually came from a European webinar.
Mhm.
And I would guess, no, it depends upon which way the air is flowing
Mhm.
on that kind of aspect. So the bottom line for me is look at where the source is, and you are correct. The patients shouldn't be worried about us. We are very worried about them. This happened
Mhm.
with HIV. Do you know why we went, just as perspective, and those that are listening are aware of what happened in the early 90s. When we looked at this, we thought what we did was when a patient said they were HIV positive, we sent them to a different clinic.
Mhm.
We double glove, we double mask, till it was determined that that was discriminating. So you know what we did? We went to uniform barrier technique. You know what that means? We assume every single patient walking in that door is HIV positive. Here's what dentists are doing now. We are assuming, I don't care what you do, the temperature, whatever, we're assuming every patient that walks in that door is COVID-19 positive. So patients should realize that we are doing our best to take care, but it comes down to the source. So I still rely on three things. Pre-procedural rinse.
Mhm.
There is some controversy over that, including ADA's comment, but there is some data.
Mhm.
And for me, it's hydrogen peroxide or providine iodine.
Mhm.
Number two, you got to wear the stuff. You don't like it? Hey, I didn't like wearing that mask in the late 80s because I wasn't wearing a mask in the late 80s all the time. I wore it when I did surgery. I'm a periodontist, but I didn't wear it when I was doing an exam. And when the first time I said, I can't breathe out of this thing. Guess what people are saying now with the 95 mask? I can't wear all this stuff. Well, guess what? You adapted in the 90s, you're going to adapt now.
Mhm.
Yeah, the face shield's inconvenient, but guess what? You got to wear it, especially if it's aerosol. So you got to wear the right PPE stuff, but don't go crazy on this stuff. Now, this is going to be controversial, but I'm a scientist. If you look at the difference between that class 3 surgical mask and that N95 mask, if you really want to look at the science, friends, sorry. The meta-analysis systematic studies do not show a difference, but I'm not going to get into that. But that's where some of the issues come in. And the third one, which has to do with products, is you've got to have the right HVE stuff.
Mm-hmm.
Anytime, and I would suggest now almost anything you do, you should have HVE. And when I say HVE, it has to be the right HVE. It has to be 8 millimeters or greater, and it has to be as close to that aerosol as possible.
Mm-hmm.
Because what you're doing is, between those three things, especially HVE and especially the pre-procedural rinses, you're doing your best at what? Cutting down the source.
Mm-hmm.
Once it's out in the air, that's all. Then we start, and you're right there. I go to the grocery. I did a webinar last week with Gordon Christensen, and he probably won't mind me saying this, but I go in wearing a spacesuit, and as Gordon says, then because he does the grocery shopping, Rella doesn't. So he goes into the grocery store, and everybody's there.
Mm-hmm.
So, I mean, we have to take an interesting concept of where this is. But aerosol, yes, I respect it. I understand it. It is, in the 90s, it was spit and blood. And today it's aerosol. Mm-hmm. So we'll get through this. I know we'll get through this.
Mm-hmm. And you've hit on a lot of the technologies that we've been covering. I've seen the research that does show some efficacy for the pre-procedural rinse as a good starting point. That makes good sense to me. Okay, you're eliminating some of the viral load and bacterial load in the oral cavity with that rinse. Hopefully it doesn't repopulate throughout the procedure enough to become harmful. The high volume evacuation, obviously, if you've got this right there by the source, I've seen statistics from some studies that 90 to 98% of the particulates can be sucked up that way. So we're doing pretty good there. But also we're seeing, and this is something, with your position at BioLase, I'd like to ask you about, which is the hard tissue laser companies, BioLase and some of the others out there in the industry, have all been touting, we use less water while using the laser than you do with your handpiece. So this should be reducing aerosol. And I want to ask you, first of all, how did BioLase come to, start putting these claims out there, and what are they backed up by? And, is using a laser really a safer option than using a handpiece?
Sure. And I'm going to begin with a conversation that any company that talks about eliminating the handpiece is very, very short-sighted. I mean, you may find that interesting coming from me, but that's very short-sighted. Let me suggest one thing before I begin. I'm a dentist first. My relationship with my colleagues is first. Everything else is second. So, having prefaced with that, using lasers, have always known since 2008 that there was definitely less aerosol than when I was using high-speed handpieces, because as a periodontist, we do use high-speed handpieces. How do you think we do bone contouring and such? We use high-speed handpieces. But I've always known that there was less water with a laser. It has to do with an erbium laser. It has to do with mechanics of the laser and the fact that we don't really require that much water. The other thing is, I always appreciated that and it's just the nature, about high-speed handpieces, that when you see the aerosol is actually moving in a lateral pattern. It has to, because of the RPMs of the burr or diamond. Whereas with a laser, there's no rotation. With a laser, even if it was the same aerosol, the aerosol is going straight down. And I knew that just from practicality. It has nothing to do with an erbium or et cetera. So then when we began to explore this, we said, well, let's just take a look. And so we did some studies. I mean, it's not difficult to do on looking how much water is produced. And what we found is, after a minute with a high-speed handpiece, just at normal high speed, you had like 50 milliliters of water. And if you used a erbium laser with the required amount, it was like, 8 millimeters of water. And so we just did a calculation of 80%. Mm-hmm. What that means, though, is this. if I have 1 minute with a laser and I have 1 minute with a high speed, I'm going to have less water use and less aerosol. It also means that if I have a laser, an erbium laser, it can't be a diode, if I have an erbium laser and I'm doing restorative dentistry, and I can utilize that, let's say on a pediatric population where I'm not using local anesthesia, where I can use it with an adult population with many of the restorations that I do that are not the large, like class 5 lesions for caries, like xerostomia patients, then why wouldn't I then, in those cases, use my laser with less aerosol and then use my high-speed handpiece for crown preps and veneers? That's basically where I'm coming from.
Mm-hmm. And now, in terms of, just this use, if you're able to use this, you're able to produce less, aerosol leaving the mouth, likely creating safer situation for everyone. Is this something that you feel that laser dentists should be touting to their patients, that this technology I have here provides a better environment for care? I mean, is that worth stating?
You hit it right on the head. And I must tell you, I told BioLace this yesterday.
Mm-hmm.
This is not just about convincing non-laser users to run out and buy a laser as an adjunctive to your high speed. This is about taking what you already have and marketing it to your patients. Because if you recall, I initially said to you, the number one thing we better do is show that our offices are safe. So if I've got this technology, and I believe this, because it's not just about volume of water. If you've seen some of these videos that we did, it's about the diameter of the aerosol. So it's not just about, if you look at a high-speed handpiece, again, moving laterally, the aerosol is large. So it's not just about amount, it's about the quantity of it, not just about the quality of it, not just the quantity. About going, so you're right. And I've asked BioLace to create, and they're working on this, to create a marketing piece that we give our dentists who own this laser a scripting that they can use with their patients. Now, some smart dentists have already figured this out and probably doing this, but I think it's the responsibility of a laser company to create that kind of marketing piece so that we can demonstrate to our patients, especially pediatric. Now, someone is going to say to us, and I know that you would probably be asking this, so I'm going to go ahead and probably think ahead of what you may be thinking, because you've done enough interviews, you know this area very, very well. But if a laser is slower than a high-speed handpiece, wouldn't it catch up? And you're correct in the fact that a laser for the initial enamel is slower than a high-speed handpiece. It's about 25%. Now, once it gets into the dentin, and especially with caries, it's actually faster than high-speed and more definitive. But in that initial, that big old, where you on a molar, it may be a little slower. But if 80% of your patients can have laser restorative dentistry cavity prep without local anesthesia, not talking about pain and anxiety, fear and anxiety, we know that's a 5-minute difference. So if you're a pediatric dentist and you're seeing 25, 30 patients a day, and there are pediatric dentists out there that have erbium lasers that have not given local anesthesia to a child in the last 7, 8, 9 years, that's 5 minutes a patient. So if we want to get to the metrics of it, you can see where I'm going with that. It may be slower, but if I'm not using local anesthesia, I'm gaining 5 minutes plus the fear, anxiety of the patient over the needle. So that could be possibly a realization in when you do all the averages.
So I did want to ask, that was definitely something I was going to ask. And I also want to ask about just some of the other research around this, because if there's one thing I'm seeing is there is a lot of opportunity for new research studies to continue to make the practice of dentistry safer for everyone involved. And when it comes specifically to lasers, there's two things that I am curious about. One is there any research that you've seen about the quantity, the viral load within the aerosol of viruses, fungi, bacteria? Is there any connection between that and the amount of water put in during a dental procedure? So, does throwing more water into the oral cavity generate a denser volume of bacterial load, viral load in the, cloud of aerosol? And then the other study has to do with lasers, and, lasers, it's a laser, it generates some form of heat. Is there any indication that it's actually having an antibacterial, antivirucidal, or virucidal type impact
Sure.
just because of the laser itself?
Well, the studies are very, very limited. With bacteria, they're not. It does demonstrate that, the more water, more aerosol, the possibility that there would be a more microbial load. The issue with the viruses and why these things have not been studied extensively, well, first of all, COVID-19 is pretty new.
Yeah.
But the other component is, I've learned it's not easy. When you do see things about it, you see RNA, DNA, but you're not, what the issue is, and that's when you see, if I get the pizza box, I better take the pizza out because it's on the cardboard. What folks are not really discerning is a live virus versus evidence that it was there. That is a very, very, very critical point, because it's not easy. And I've looked at some, I don't know if you've seen these contraptions that these people try to do to collect the aerosol with a virus in it. But believe me, there is a whole art and science to that. Bacteria, much easier. So first of all, I would say to you, I wish there were studies. There needs to be studies. But right now, again, my data set tells me that we've not been able to truly isolate a COVID-19 in a dental aerosol at this point. Doesn't mean it's not there. Means that maybe remnants of it there, but we don't know if it's there. But I do want to talk about the heat. No doubt that a diode laser, now I'm switching on you.
Yeah.
A diode laser, especially, I'll get a little technical, especially with an initiated tip. That thing is going to get up 150, 200 degrees centigrade like that. This virus is not that difficult to kill. As you know, anything probably over 60 degrees centigrade probably kills. So if you use a dental laser, especially a diode, on that, then you probably have a thermal reaction, which is what you're leading to. So I highly recommend for you dentists and hygienists out there that have a diode laser, especially using a procedure we call laser bacterial reduction. And if you're finding yourself decreasing your ability to use your ultrasonics, that the next best thing, and you're having to go back to using manual instrumentation, if you already have a diode laser, wouldn't it make sense to use laser bacterial reduction, and especially from a thermal standpoint, laser-assisted periodontal therapy? That just makes sense to me, to overcome the possibility that you can't completely disrupt the biofilm like you could have with your ultrasonic. So I'm giving hygienists sort of an uplift. Yes, you're saying, oh, I can't use my ultrasonic anymore. Well, if you can't, and you've got the diode, I'm helping, because DSOs are also looking at this, embracing this. Use your laser as an adjunctive to your manual instrumentation, and you're going to be okay. Yes, but there is a thermal activity. Most lasers have thermal activity. I just become a little reluctant because I don't know the studies to really put my hat on that, because there's some laser companies out there talking about, 1200 degrees centigrade. Well, you can't have your cake and eat it too, Noah. You can have a lot of heat, but it's not hurting anything. When you're working on teeth and gums, I mean, you can't have both, is my point.
Yeah.
So if you're shooting something at 1200 degrees and you say, well, it's not affecting anything but the virus, 1200 degrees, that affects something, including the pulp. So, so you can see there's a lot of misinformation out there. And I wish there were more studies. It's just, they're not.
Yeah, and it does seem to me that there's a whole range of research that the dental industry could benefit from. Are there certain things, you just said you wish there were a few more studies, are there certain things that you'd really like to see more research on in the near term, because it could help right now?
Now, what we are trying to put in here is the adjunctive use of the laser if you have it. Because by my calculation, 80% of all your restorative dentistry from a standpoint of caries could be done with that laser, leaving the other for that, and that might even reduce some of the PPE. But for the most part, if we actually look at what we're doing and use our high speed just for those preps, if we use the diode laser in the hygiene operatory, I think that we can truly get down to where something is reasonable for us. And we can continue practicing dentistry like we should. Well,
Dr. Lau, we've reached the end of the time period I've got for our interview today, so I really do appreciate you making the time to speak with us. This has been a really interesting conversation, and we'd love to find another time to continue speaking with you on these and other topics. So thank you very much. We really appreciate it.
Thank you. Appreciate you having me.